Hello, everybody. My name is Barak Gaster, and I'm a primary care doctor and dementia expert at the General Internal Medicine Clinic at the UW Medical Center at Roosevelt. And for about 7 years or so, have really been focusing in on how can we do a better job identifying and managing dementia in the primary care setting. And I'm so happy to have you joining us today. And I'm joined today by my colleague, Dr. Jackie Rates, who I'm going to let her introduce herself as well.
Hi there. I'm a family doctor and I help teach at the residency, the family medicine residency here at the University of Washington. I've been faculty since 2005. I have a primary care clinic at Harborview Family Medicine, and I also have a CAQ in geriatrics and do some nursing home work and palliative care with Harborview Post-Acute Care Services and at Montlake. So I will let Brock take it away.
Great. Yeah, so you've got two primary care doctors who are experts in dementia here to help you figure out how to do a better job with this disease. And so neither of us have any disclosures to disclose. And so let's start a little bit talking about why is dementia so hard. And so much of it is that it's the diagnosis is just can be really tricky, especially in its early stages. It's tempting for patients and for us to skip over it just because it is a psychologically difficult and complex thing to engage with. And so, but the real kind of message that we want to share with you is how much really meaningful intervention we can do if we identify cognitive impairment earlier. And it really is a lot about just improving communication. And we've all been in that situation where a patient is just sort of slowly sort of drifting away, and we are really not quite sure what's going on, but sort of more and more it seems like they're not really following the care plan that we're setting, and just it can be so isolating for people when they are slowly drifting into cognitive impairment without it being identified. And so really maybe the most important sort of thing that can come out of an earlier diagnosis is that better communication, getting family involved, that will really help you do a better job. It'll help you do an easier job to not have to be in that sort of murky, really hard communication state where you are more clear that you can get a family involved to help you to care for the patient. You can really do so much better aligning care, setting goals of care, which in so many ways is better care if you know that maybe the most important organ in their body is slowly having some degeneration. You can connect people to community resources. That's a really big part of the series that we're going to be presenting. And there are just so many really important proven interventions that we can make that really will improve brain health. So treating sleep apnea, treating hearing loss are just two examples of the interventions that we can make to really keep people's brains healthier if we can make an earlier diagnosis of cognitive impairment. And this is just such a big, hard part of primary care right now, but it's really the forecast for the next 10 or 20 years that as the baby boom generation enters into that age of 70s to 80s, when they're at higher risk of Alzheimer's disease, that the really solid forecast is that we are going to be facing a doubling in the number of people living with dementia in the United States. And so if we think it's hard now, it's really going to become overwhelming in the future. And this is just such an important time for us to really get a better handle on how to identify dementia and manage it. This is really maybe the generation that is going to live longer than any generation in history. We're doing such a better job of treating heart disease, treating cancer. More people in the baby boom generation are going to live into their 70s and 80s than ever before. And they are just right now entering into that cusp. That it really is this silver tsunami that is on the way, that this is the time for us to get better at identifying and managing this disease. And so these are the three parts of the series. And today is the first part, which is making a diagnosis of cognitive impairment. The next part, which starts next week, is setting a plan for the newly diagnosed patient. And then the third part is going to be managing dementia as it progresses, because we don't just want to give you tools to do a better job of identifying dementia. We want to help you to know how to manage it better as well. So the learning objectives for today are how to perform a cognitive evaluation, how to identify contributing and reversible causes of cognitive impairment that you can fix, and really to delve in a little bit into the difference between mild cognitive impairment and dementia, which are really two separate diagnoses that we're going to talk about. And so let's start with a case, an 82-year-old woman who's in your office for a wellness visit. She's generally very healthy. She takes losartan for hypertension and occasionally some ibuprofen, occasionally some Ambien. And she happens to mention, "I've been worried about my memory." So a very common scenario. And you may be somewhat tempted to just reassure her and say, "Oh, me too, don't worry, you know, I've known you for years and you're fine. It's normal to get more forgetful with age." You may be sort of tempted to just, "Oh, I'll just refer you to the Memory Brain Wellness Center at Harborview," realizing that it may be a 6-month wait till she gets an appointment. And when that time comes, she may have forgotten sort of why the appointment was made and may not even show up for it. You could try to drop everything then and there and do a 15-minute cognitive assessment and just kind of blow up your whole clinic session. Or you could offer her a cognitive evaluation, a longer full visit with a family member present, and say, "This is maybe worrisome, but I can help." And so these are the three situations in which this most commonly will come up, where it's really the first step is just to be aware. And so a patient or family might mention a concern like this patient just did, but very, very commonly on that annual wellness visit questionnaire, there is a question about memory, which is required by Medicare, which asks, you know, do you have a concern about your memory? And it is not too uncommon that somebody will circle yes to that question. And oh my goodness, for years, I was just never quite sure what to do when somebody circled yes to that question. And so that is another scenario very commonly where this is a really important moment to be aware and think about what to do next. But really anybody in your clinic, your front desk staff, your medical assistant, or you could start noticing that a person is showing up to their appointments at the wrong time. They're not picking up the medicines that you prescribed for them. They are just not, they sort of wander away and don't get the labs that you ordered. All of these clues that really should sort of make you think, gee, is there cognitive impairment going on? And in any of those three questions, it's really the next, in any of those three scenarios, the first thing that should come up is deciding how strongly should you encourage somebody to get a full cognitive assessment. So are they just sort of noticing things that are normal aging? Or is this really a worrisome situation that you absolutely sort of have to almost insist that someone returns for a full cognitive evaluation that you can do? And so the three questions that I sort of most highly recommend in a situation like that is, do you feel like you're forgetting something that just happened, like repeating the same story or asking the same question 30 minutes later? Is it harder to do a complex task that used to be easy for you, such as making a complex recipe or organizing your documents? Do you find yourself suddenly being disoriented or unsure where you are in a place that you know well? Those are three absolutely worrisome signs that if any one of those three are present, it's absolutely essential to do that they have a cognitive evaluation. But if you can identify that really their concern is isolated to something like, you know, I just find myself misplacing my keys more often, but then I can find them, or it's taking me longer to remember somebody's name, or I might have gone upstairs and I sort of don't remember why I went upstairs, but then eventually I can retrace my step and figure it out. Those are situations that are more consistent with normal aging and are less worrisome. And so to help to remember those three questions, we have actually created a new dot phrase in EPIC that's called Cognitive Quick Questions that you can favorite. We've also created a new epic smart set called Cognition, and that dot phrase is in that smart set. We also have on our website, cognitionprimarycare.org, a single one-pager form with these 3 questions on it that either your medical assistant can give or you can give to patients. And so this is what that form looks like. It's called the quick questions if memory is a concern. And again, it's got those 3 questions on it where people can answer yes or no. And then at the bottom, it's the three much less worrisome type of symptoms that are much more consistent with normal aging. And you can either download this form from our website, you can find it as a dot phrase, dot cognitive quick questions, or you can find it in our smart set Cognition. And again, if there's a yes to any one of these questions, that is worrisome and you really want to do a full evaluation. And so if a dedicated cognitive evaluation is warranted, the big sort of light bulb point that is going to make that visit go so much better is if you can get a family member or a close friend to come with them to that visit. So somebody who spends a lot of time with that patient really should come to that visit. And I can tell you that even the world's sort of best, most experienced dementia experts really need that observer input to sort of give you that sense of how is the person sort of doing navigating through the world. And so really you want to try so hard to get a family member or a close friend to come with them to that follow-up cognitive evaluation visit. It's also going to work so much better if you can schedule that as a longer slot appointment, which is it's hard to do given how difficult access can be for all of us, but I can tell you that this is a cognitive evaluation that there's a lot to it. We're going to get to what's in it. It's really hard to do it well in a short slot appointment. And the big change that happened in 2021 is the number of RVUs for a level 5 visit actually went way up, and it's now double the number of RVUs for a level 3 visit. And if you do it by time-based billing, it only requires 40 minutes total on the visit, including preparation time and charting time, not just face-to-face time. So it really is practical and conceivable to do a long slot appointment in which you can get paid for twice a level 3 by billing it as a level 5. And that is really the way to do a cognitive evaluation visit. So that cognitive evaluation visit is going to have 3 parts to it. There's going to be a checklist of reversible causes and other factors that you can fix. And again, that's a dot phrase that we've created called dot cognitive checklist, which is also in the Cognition smart set. You want to get input from the family member or friend who comes with them. And then you're going to do an assessment of their cognitive function using a Montreal Cognitive Assessment or MoCA test. So here's what that cognitive checklist looks like. And again, this is the smart phrase dot cognitive checklist. And it's going to remind you to make sure that the easy things like checking their B12 and thyroid function, to look at their medication list. You want to be really paying close attention to medicines that might be sedating or anticholinergic that might be making their cognition worse. You want to ask them about alcohol. And here, the really key important teaching point is that that this is not necessarily sort of looking for substance use disorder or alcohol use disorder. You're really looking for somebody who has maybe been drinking 2 to 3 glasses of wine or 2 to 3 beers a day for their whole lives, and it's never been a problem for them. It would never have qualified as an alcohol use disorder. But now that they are 70 and now that they are worried about their cognition, they feel like their memory isn't as good, you really can tell them that reducing their alcohol intake from 3 to 4 drinks a day to 0 to 1 drinks a day is going to keep their brain healthier and they're going to think better. And then again, we want to be thinking a lot about these conditions where if we treat them, they really do improve people's cognitive function. So untreated or undertreated sleep apnea, untreated or undertreated hearing loss, wearing your hearing aids, untreated or undertreated depression are all comorbidities that can worsen cognition, that can make somebody's brain work better and keep them healthier from a cognitive standpoint as they get older. And again, these are in the EPIC Smart Phrase Cognitive Checklist. And so here's what that checklist looks like. It goes through those comorbidities. It's got really nifty vanishing tips that reminds you why you're asking them, and then those vanishing tips disappear once you sign your note. It's got a reminder about visual hallucinations, which is a tip-off to Lewy body dementia that we're going to talk about later in the series. Reminds you to do a MoCA test, reminds you to get input from a family and friend, and it's even going to pull in when their last B12 and TSH were. And again, this is what the SMART set looks like. And so this is the Cognition SMART set, where that dot phrase cognitive checklist is in the SMART set. And it's got the key dot phrases and documents that you'll want to use. And so the evaluation of the cognitive function is a combination of doing a MoCA test, assessing their cognitive function, and then getting input from the family member or friend who has accompanied them to the visit. How do you get that family observer input? And it's very similar to what those 3 worrisome questions were that you used to help to decide whether to do this cognitive evaluation visit. You want to ask that family member or friend, does the person seem to be repeating the same question 30 minutes later? Do they seem to be losing the ability to do a complex task that they once found easy, like doing a complex recipe or hanging holiday lights or preparing documents for their taxes? Do they seem to get disoriented in a familiar place? So not in a place that they've never been to before, but in a place that they should know well, where they suddenly seem a little sort of stuck and lost and aren't sure which direction to turn. Those are the 3 questions that are at actually the bottom of the cognitive checklist. But some of you may prefer to use a fuller validated 8-item form called the 88 that has these 3 questions on them plus more. And this is what the 88 looks like. And again, this is an 8-item tool to get input from the observer that you could use, that is available in the SMART set. It's also available on our website, cognitionprimarycare.org. And this is a very well-validated questionnaire that you can score, that really you can put together with a MoCA test to really make an accurate assessment of somebody's cognition. And so here's, again, the checklist, and this time with those vanishing tips shown, and showing at the bottom of that checklist how those 3 questions are there. So you can either favorite this dot phrase, cognitive checklist, and make a button out of it, or you can find it in the Cognition SMART set. And so let's talk a little bit about what the MoCA is about. So this is the best validated tool for mild cognitive impairment in the primary care setting. And so this is more sensitive than the mini mental status exam. It's very, very well validated. There are dozens of studies that have shown that it is a very accurate assessment of cognition in the primary care setting. And here it shows you what the scoring is. And it's important to sort of acknowledge that somebody may very well end up with this kind of in-between or uncertain score. And if somebody does get an in-between or uncertain score like that, that's where incorporating family input is going to be so important, following somebody over time. That's a situation where you might recommend a full neuropsychological evaluation. So that's like the full 2-hour battery of tests that, at least right now at UW Medicine, we're having a really, really long wait to get into appointments for those, but they are there. And generally Medicare will pay for them. And so I really would do that. I would recommend referring somebody for that if the person is very, very anxious and uncertain. If you feel very, very anxious or uncertain, that could be a next step to get a more full evaluation of their cognition. But if their score is very low, like less than 20, then dementia is very, very likely. And so what I really, the biggest, most important teaching pearl for doing the MoCA test is to make sure that after you've done it, you put the results into the behavioral medicine tab, which is right next to the PHQ-9. And the reason that it is so important and useful to do this is you want this to be a result that you can easily find later and perhaps track over time. So if it's just sort of buried as a free text in your note, or it's just buried as a scanned document in media, it's going to be really, really hard to find it later and track it. You want it to be like a test result, which you can make it that by going to the behavioral health tab and going to the MoCA section, which is right next to the PHQ-9, and enter in the numeric results of the MoCA test. And so the options for entering in those numbers, it's very, very similar to entering the PHQ-9 numbers from a piece of paper. If you do a PHQ-9 on paper, it takes about 20 seconds. You could train an MA to do it. It doesn't come up that often, so you may be in a situation where you would be doing it yourself. But really, the most important is to sort of do what works best for you in your clinic, but to make sure that that test result does get entered into that flow sheet so that you can find it and other people can find it later. And best practice would then also be to have the paper MoCA form sent in for scanning, because it's got the little place where people have sort of drawn a clock, and it's useful and best practice for that to be scanned into somebody's record as well. But it's not as important as getting the numbers into the flow sheet. Let's talk a little bit about the difference between delirium and dementia. And this is really, really important when talking about a MoCA test, because the MoCA test is just not accurate during or after an acute illness. So if somebody, it is just so common for the elderly to have a transient drop in their cognition related to an acute illness, and that is not dementia, that is delirium. And a delirium, especially after a serious, severe illness like that required hospitalization, can actually last for weeks. And so it's important to not do a MoCA and diagnose dementia soon after an acute illness. But you do want to pay attention to when somebody develops that delirium, because that is, developing delirium is absolutely a warning sign. The odds of dementia, either being present now or developing later, are much, much higher in somebody who has had a delirium episode related to an acute illness. So let's put it all together. So you're going to put together the MoCA test result and the input from the family member or good friend. And if, say, their MoCA score is less than 20 and their observer is noticing worrisome changes like asking the same question 30 minutes later, and they're also starting to have difficulty with activities of daily living like bathing or dressing or cooking, then that is a diagnosis of dementia. And you do not need to wait the 6 months to get them into the Memory Brain Wellness Center for a neurologist to make that diagnosis. In this scenario where the MoCA score is low and the observer is definitely noticing worrisome changes and is also reporting that they're having some difficulty with activities of daily living, then you can make a diagnosis, and you should make a diagnosis of dementia in that situation. But what if the MoCA score is intermediate, which is going to come up a lot? What if their MoCA score is between, say, 22 and 26, but the observer is saying, yes, they are definitely, they really, I went to the store with them the other day and they should have known sort of, how to navigate through the store, but they really felt sort of lost and stuck there for a while. Or they are, I definitely am finding that they're telling the same story again 30 minutes later and forgetting that they had just told it. But they're still fully independent. They're still dressing themselves, they're still cooking, they're still cleaning their house. So that is a diagnosis of mild cognitive impairment, which is really different than a diagnosis of dementia. And let's talk a little bit about, what that difference is. Like, so what is this thing, mild cognitive impairment? So again, the typical case is somebody who has kind of an in-between MoCA score, worrisome changes are noted by an observer, but they are still fully independent, activities of daily living are intact. That is mild cognitive impairment, whereas a diagnosis of dementia really requires somebody to start losing some independence with sort of activities of daily living. The key point is that mild cognitive impairment is not simply early dementia, because about a third of people with mild cognitive impairment will never progress to dementia. You could follow them, and you may have experienced this. Myself, I have definitely experienced this in primary care, where 5, 10, 15 years later, that person with mild cognitive impairment still has mild cognitive impairment, has not progressed to dementia. And yet about 70% of people with mild cognitive impairment do eventually progress. Most people who have mild cognitive impairment do have early Alzheimer's disease, which is a progressive neurodegenerative disease, but not all of them. But there are just so many important things that you can do by diagnosing that mild cognitive impairment to focus on their brain health, to reduce their alcohol intake, to help them make the connection between wearing their hearing aid and keeping their brain healthier and working better, by treating their sleep apnea, by wearing their CPAP, and then repeating a yearly evaluation of their cognitive function. So at the end of this evaluation, there's going to be a few different scenarios that you might be in. It may very well be that their evaluation looks okay, and then you can then really discuss ways to keep their brain healthy and consider repeating the evaluation in 12 months or 24 months if they'd like. You can really, but even if their evaluation is okay, you can identify contributing factors to really keep their brain healthier, to reduce their alcohol intake, to treat depression as one of the things that may be a factor in their sort of sense that their thinking isn't as good as it used to be. If you make a new diagnosis of mild cognitive impairment or dementia, you really want to have a good phrase ready to go, because you are not going to have time to do the full, let's sit down and talk about what this means and make a plan. You really want to have a good phrase ready to say something like, this is a lot to take in and work through. Let's schedule another appointment soon to review what this means and make a plan, and really strongly consider another long slot appointment that you can again easily bill as a level 5 visit. Encourage a family or a friend to attend that visit as well. You really want to avoid the diagnose and adios phenomenon, which is really, I think, one of the biggest pitfalls of doing more cognitive evaluation if you're not sort of ready and prepared to have them come back to really talk about what this diagnosis means and making a plan. So takeaways from today is that we can do cognitive evaluations in primary care. Consider using the phrase cognitive checklist. Really so important to have a family member or a close friend come to give observer input, essential for that evaluation. You're going to want to combine a MOCA test with that family or friend interview. Consider either asking the 3 questions of the observer or using the fully validated 8-item questionnaire called the 88, and really addressing brain health and key modifiable risk factors for cognitive impairment are just the things that we can do in primary care to keep people's brains healthier. All right, so that's the end of part 1. Part 2, we're going to cover these other important next important topics, and hopefully you all have that on your calendar, which is either next week or the week after. Look forward to seeing you again for that part 2, and that's going to be titled Making a Plan for the Newly Diagnosed Patient. And so we've got time for questions now. Don't forget to go to the website cognitionprimarycare.org, where you can download summary tools, and make sure to, if you haven't already, type your name into the chat as a sign-in, and then Jackie is also going to put a link into the chat now to fill out a really short, less than 1 minute CME type evaluation for this session, but we'll also be emailing it to you later in case you don't have time to do it right now. All right, and so now on to your questions.
Yeah, and we didn't have any questions in the chat, so feel free to unmute yourself if you have any questions.
I have a question.
Yes.
Hey, okay, so first of all, excellent presentation. I am learning a lot. I have checked out your dot phrases in the past, and so thank you, first of all. Second of all, I wonder a couple of things. One is a systems thing, like if you're recommending like a close follow-up, and you mentioned access, you know, like I mean, I just think it's kind of brutal to say, come back, be nice to have a long visit, which is difficult in our system. But like if someone has to wait 6 weeks, I guess, is that too long? So that's number one. And number two is
actually, let me hold you off on number two, because that's a big package to unpack right there. And so Jackie, do you want to sort of answer that one? But hold on to number two. We're
Yeah.
gonna get to it, but let's add
I think it really depends on the patient and the scenario. If this is clear, this has been going on for a long time, the patient's living with family, they're safe, then it's not so long to wait if they have to wait. If they're living by themselves, the meds are a mess, we don't know what they're taking, the family, then we have to somehow try to get them in, because it's probably a safety issue. But I think it can wait if the patient has somebody who can kind of keep an eye on them, because we can't keep an eye on them. They might need a higher level of care. And if it's really, a crisis situation, there are a few crisis teams that can help intervene in the area, like the GRAT program.
But yeah, Kim, I absolutely acknowledge you are correct. That this is hard. This is a hard diagnosis. It's a hard communication conversation to have. It's hard to get people in. It's hard to get people back. But there are really few other situations in primary care where we might make this really sort of like, as you call it, brutal diagnosis, and not have easy access to a specialist to immediately hand somebody off to. And so it is.
Well, not even a specialist, to me.
Yes,
the
exactly.
primary care.
But especially, I mean, if you diagnose lung cancer, it's like relatively easy to get somebody into an oncologist or et cetera. But so it's hard, it's easy. It's not, there's not we don't have the easy solution to make it easy, but we really do just sort of want to sort of make the point of how important it is to do your best to get the patient back, and ideally have it be a long slot appointment and have a family member come. And next session, we're going to be talking a little bit more about sort of what that visit will look like and how to do it. So before we get on to your question number two, let me first ask if anybody else has other questions.
There's one in the chat. Any supplements you'd recommend when patients with memory concerns are asking for them? You want to start?
Yeah. So, I mean, this has been, like the holy grail. Like people have been, so many studies have been done trying to find an easy supplement that would help cognition. And, it's just a graveyard of littered failed trials that have not shown any supplements to really help. And so, I think, as long as you have ruled out B12 deficiency, I would not necessarily say that there is a supplement that will help. And we're going to talk about managing cognitive impairment in a little bit. But in terms of, is there a supplement to take where I can reduce my risk of getting dementia, I would say, unfortunately, no.
Yeah, and I think, our take with diet and exercise and dementia, it's similar to other chronic diseases. You want to eat a healthy diet. You want to be active. We know that keeps people functional for longer, no matter what their underlying chronic diseases are. And, I, in general, for my primary care patients, dementia or otherwise, I try to encourage a healthy diet. And if they have maybe a diet that's less than optimal, I might recommend a multivitamin, but there's no evidence to support that per se, in the absence of known deficiency.
Yeah, but I would think of this as all of the things that reduce the risk of heart attack and stroke, like, eating well and eating healthy diet and exercising, are all probably applicable to reducing the risk of dementia. And so I think, talking about heart health / brain health is a good probably way to sort of pivot if somebody asks a question like that. All right, before we get to Kim's question number two, is there anybody else that has a question?
Question. I had a couple of patients who are non-English speaking or or, you know, maybe just don't seem like it's really hard for them to engage with doing a MOCA test. And you start and then they look at the first one, they're like, oh no, I just can't do it. How do you sort of engage people when there's a little bit of that barrier?
I've always found it a challenge. And recently I had a patient who was sent to the memory and brain wellness clinic, and they sent me a note back saying, wow, we really struggled. We couldn't really get very far. So I think even the experts, it's hard. I mean, MOCA has been translated into many different languages. Of course, we recommend an interpreter, an in-person interpreter if possible, to optimize things and to do it in their language if it's available in their language. I do think this is sort of where the family history can help a little bit, about asking, you know, what they were like 5 years ago. Were they cooking big meals for the family and now they're not? If not, why not? Can we really, you know, pin down some specific activities that have changed over time? So I will sometimes start in on that MOCA and maybe do parts of it that I'm able to do, and then or having to do parts of it over several visits because it takes a really, really long time, and then rely on that family history.
Yeah, but you've hit on a very, very difficult sort of issue, Megan, of that language barrier can be really, really hard when there's cognitive impairment. And so I think Jackie is exactly right that, you know, if you go to mocatest.org, you can find MOCA in many different languages, and that's probably sort of one of the places that would be best to start.
And there might be some new things on the horizon. There's a lot of interest in finding ways of testing for mild cognitive impairment and early dementia. And so there's a lot of research efforts going on, but not a specific recommendation yet.